It's the morning, so I wish to pick your brains a little bit and think about the context of viruses as a self-replicating machines. And this context is actually somehow old, and it was devised by a mathematician, Janus von Neumann, who was actually Hungarian. And we could think about machines which replicate within machines, because we are self-replicating machines, and viruses replicate within us. And actually this concept is very detailed. If you would like to read about it, and I really welcome you to do so, because there is construction element in every virus, and replicating element, and controlling element, and every virus actually can be fit into the context of self-replicating machine, instruction which is DNA or RNA based, and then it uses our machinery to replicate, obviously. And this concept is used throughout the viruses all the time. Even some natural structures, DNA structures, use this replication within a replication, and this is like the DNA self-replicating models just for you. And if you would look at the cell, we have an infecting viron, which is the input device. Then we have all the infected cells, which again go within this model of a self-replicating machine, and the budding virus, which is going into the infection. So just to wake you up, maybe, and put the machinery in context. So we have HBV and HCV global perspective. And if we would look at the perspective of HBV and HCV, we have increasing number of deaths. And if we would like to think about it in the context of general epidemiology in the world, we have had tuberculosis very recently as the primary infectious diseases mortality cause, and it has actually declined, and now the hepatitis is taking the lead. So we will be facing mortality related to the hepatitis in the near future, probably higher than HIV, than malaria, than tuberculosis. So we will see how it goes. Similarly to the previous presentation, we have WHO 2030 targets to stop HBV and HCV. So this target is actually related to the vaccination coverage, and we would like to receive 90% coverage across the world for Hep B vaccination, mother-to-child transmission also to 90%, but the treatment targets are approaching 90% for 2030, both for Hep B and for Hep-C, for infection, diagnosed, and treated people. So we hope to get there if we want to stop this self-replicating machines from going on. And in the world, we have like 18.5 million of estimated, in the European region, of people living with chronic Hep B and 15 with chronic Hep-C. Mortality rate is increasing, as I told you, and if we want to deal with Hep-C epidemics, we would need 7% increase in the net cures every year to reach this 90% target by 2030. But if you would like to address the issues of elimination of Hep-C, basically, and Hep B in the future, we have to think about multifaceted issue. So the drug pressure and vaccination rollout and price competition, which is happening in the world now, surveillance of the transmission networks, and I will show you our data on this for Poland and for Europe, but it will have to be put in the context. Viral resistance, which is emerging now, which we are discussing, treatment of Hep-C complication, which is obvious, and diagnostics in point of care and testing. If we would think about Hep B, though, in the European context, the prevalence of Hep B is around 1.6, 2% depending from country to country. And these prevalences for Hep B vary very much. And there are a lot of gaps in the data, but we have quite a few people living. And look at this slide. This is the success of vaccination. So the success of vaccination in the countries which rolled out the vaccination in the first years of life, basically the vaccination is in the first day of life, is the decrease in the prevalence. This blue light blue in the north of the world is the other countries which rolled out the Hep B vaccinations, and the prevalence in these children below 5 years of age is less than 1%. Basically, the best estimate is 0.4% of the prevalence for Hep B in the countries which have vaccination programs in place. Even though the data vary for the adult population, and there is a lot of data missing for the Central and Eastern Europe, and look at the confidence intervals for the data, they are sometimes very broad, like for the Greece, which is almost 3% for the seroprevalence of HBs antigen, but we have the data accumulating. And the prevalence across the Central European countries is very different, from almost 10% in the Kyrgyzstan to 0.42 in countries like Poland, and even lower for Slovenia, 0.3. So the country which has the vaccination in place has much more decreased prevalence for Hep B. And if we would look at the region, the Hep B prevalence is decreasing in the countries more or less consistently over the last years. All these countries have vaccinations in place. So acute Hep B infections are disappearing, and these programs are almost working perfectly. Okay, and the last important issue is the distribution of Hep B genotypes, and here thank you to the Slovenian authors. We have very nice review on the genotypes of Hep B with A and D, and mostly in the region we have A in the Central Europe, and then going to the D in the Eastern Europe, and there are differences in the seroclearance for hepatitis, for HBe antigens and for the negativity, and I welcome you to read if you are interested in this. If you would like to think about Hep-C in the European context, again, there are almost 14-15 million of people living in Europe with Hep-C, but look at the new infections. There are quite a few new infections, and if we want to address Hep-C in the future, we have to think about 60.61 of incidence of a new infection per 100,000 people for the European region, and this is mostly due to injection drug use, so a lot of people in this context acquire new HIV. And also we have seen the slide on migration for HIV. For Hep-C, in the Central and Eastern Europe, the migration is not so important. It's much more important in the Western European countries, but we have to think about it and look at the surveillance for the migration, and it will be something to do in the future. And if we would like to think about the key things which drives the Hep-C and Hep B epidemics is the injection drug use. And actually, thinking about injection drug use is thinking about something which is multifaceted. So we have like chemsex now, people who firstly inhale or take intranasal drugs and then switch to the venous drug use. Homemade cheap drugs like Polish compote, which is like a history of Poland, which nobody knows how to prepare anymore. Now people have switched to the pseudoephedrine and manganate concoctions. So these are very cheap drugs for the people, and obviously if you have a if you have an injection drug user and they go into the drugs, they face the insurance issue, marginalization, criminalization, and the things which will be uncovered as the DAA programs expand with the treatment is the reinfection risk. So far, we see the reinfections in the countries which have been using DAAs for quite a few, like Germany, for quite a few years, like Germany, but we will see this in the Central and Eastern Europe in the near future. And if you would like to think about the countries where the injection drug use is the most prevalent, there are quite a few Central European countries which are in the lead. So here is the Ukraine with 320,000 people estimated to be using drugs. So we have a second region where the most of the people who inject drug live. And the prevalence of HBV among people who inject drugs in the region is also very high, reaches more than between 10 and 20%. And here we have Belarus, which has almost 10% of HBs antigen seroprevalence among people who inject drugs, and more than 80% basically of people who inject drugs will be Hep-C infected, and this is like a common knowledge, everybody knows that. And here we have a signal from Romania, from the region. So there is quite a few infection hotspots in the Central and Eastern Europe for the Hep B and Hep C. And if you would like to think again, I try to pepper this presentation with some country-specific things. So we see this in quite a few people, Cns Manganosis, where people use pseudoephedrine, and I think most of the people who work with people who inject drugs in the region have seen this, that people actually oxidate pseudoephedrine, inject it. It's a short-term acting drug, and you get the Cns Manganosis in these people. If you ask radiologists what to look for, they will see the manganate around the cerebellum. You just need to ask them specifically, and there will be cerebellar sign after drug use in this patient. Usually this is something which is irreversible. So if we speak about elimination of Hep B, Hep C, and HIV among people people who inject drugs, we need to think about harm reduction programs, and this is the slide I have taken from the presentation from the last year. Opioid substitution widely available except for Russia, Turkmenistan, and Uzbekistan. Coverage is very variable for harm reduction and needle and exchange programs, and there is still the target of 200 needles being provided per client per year, which is different from many countries, but the target is there, and we should think about it. And the testing, which is now expanding quite a lot to point-of-care testing, to rapid care testing, and many countries offer even point-of-care finger prick test for HCV, which is like the initial testing, and it will be very available freely in voluntary counseling and testing points in checkpoints. So we will see probably this test and treat strategy going very well, and this is the target which needs to be seen. And the DAA treatment uptake, as we see across the countries, it has been switching. So we see the DAAs which are there and DAAs which will be there. Their place is settled, so the countries in the region are using the drugs and will be using them in the future. There are some restrictions still. Every year these restrictions are being loosened. So Poland has actually loosened the restriction of Hep-C use 2 years ago. Now we have unlimited access regardless of the fibrosis. Some of the countries still use the fibrosis stage restriction, but it will be probably lifted as the population of people who are treated is decreasing, or as the patients who are more ill with longer infection will be treated. And these restrictions still are in our minds very often, so there is also the question, what should we do when we have a person who is actively using drugs? Should we give them the treatment as priority? Should we wait until they stop injecting drugs? How long should we take? What about the alcohol using people? And on one hand, we need to think that these people have a risk of reinfection, but they also have a risk of spreading and fueling the epidemics. So if you want to target the Hep-C epidemics, we need to think which is the optimal moment for the person to be treated. I think as soon as feasible would be the good option. If somebody is actually not able to take drugs, they will probably not be the best candidates for the cure. But very good review from Journal of Virus Eradication, which just came out last year, and showing the treatment disparities if we want to address the target of 2030 for the future. So just showing you the slide in the context. Ratio 5 to 1 means 5 more people reach elimination of Hep-C than are newly infected in the country. 1 to 1 means equal number, and 1 to 5, 5 times less people get the treatment and achieve SVR than get infected. And look, above this 5 to 1 line, so the countries which are very well set to the elimination in the country are basically Western European and North American countries and Australia. Egypt is there as well because of the early access program, but most of the countries in Africa and Central European countries are well below this line. So here, even the rollout of treatment is not sufficient to cover the number of new infections because of drug use and because of new transmissions. So if we want to reach the target by 2020, we would need to reinforce the treatment and prevention practices. So the net cures in these countries for the Central and Eastern Europe is actually negative still. So there are insufficient number of people being treated compared to the number of new infections, and this is basically very consistent across the Central European region. Most of the countries have negative net cures for Hep-C. So this is the first part, and I wanted to show you a little bit of our data on the transmission networks, which may actually also hinder the hepatitis elimination targets. And the first thing which we need to discuss is actually the acute Hep-C infections, and there is a shift, at least for Poland. It used to be genotype 1A, and now it's genotype 1. It used to be genotype 1B, and now it's genotype 1A in MSM in people who have had history of syphilis, and genotype 4 is coming. So we see these transmissions among MSM, which are being now revealed in higher number of populations, and these transmissions are clustered. And we have been trying to calculate the clusters for Hep-C, and we see that either the cluster is MSM only or IDU MSM mixed. So we see the shift between IDU and MSM people, and these clusters actually are peppered across the country. So they are moving between largest cities, and these are genotype 1A clusters, and you could see that there are at least 4 clusters which have been found, and one cluster is actually the cluster with primary Hep-C resistant to Cimeprevir. It's not important in the context of current DAA, but it may be important in the future, so the virus can be transmitted with primary resistance. For Hep-C, this can happen as well. And these are the small clusters, and we have seen very similar clusters among the cities which have very important gay-sex scene, like Berlin, London, and Barcelona here. So there are data on this clustering as well. So maybe if we would do the European study linking the sequences of Hep-C between Europe, we would see the huge movement of Hep-C between the large cities. We don't know that. Molecular data may reveal this in the future. On the other hand, we have like genotype 1B, and you can see this in the red. This is the Krakow-based huge MSM cluster, which is now expanding in Poland. So people famously go to Krakow for the party and come back with Hep-C, and then spread it across various Polish cities. So I think this happens for most of the European cities as well, but we have hotspots for Hep-C where people go, inject drugs, or have ham sex, and then transmit the virus across the country network. The reinfections will be revealed as the DAA progress, and it is still not seen too much, but in, again, MSM, the German data show that up to 8% of MSM gets reinfected, even being cured. For IDUs, these rates are slightly lower, but the data are not as consistent because of the treatment. And lastly, a little bit of data on the baseline resistance for the region. For us, we can see that there is quite a lot of prevalence of 80K mutation in the baseline sampling, because we have done like the surveillance for most of the Polish cities. But interestingly, if we would look at the NS5A resistance across Poland, this is the people who have never been treated. We have 5% of people who have primary resistance for the NS5A mutations, and as the fibrosis progresses, the mutation is much more prevalent. So what this could mean is that the virus is actually selecting for mutation within the time period of infection, and we can have up to 20% of people having already drug-resistant virus before the treatment if there is a cirrhosis as well. And the key mutation Y93H is there in 11% of people with cirrhosis. There is no NS38 resistance in the context of fibrosis there, so the resistance for NS3 is not as important in terms of transmissions. And we have even checked if the resistance for NS5A is clustered or is it progressing within the timeline of infection. We have done the phylogenetic analysis, and it's actually never clustering, so it's de novo mutation, so there is probably a selection of NS5A resistance mutations with a virus which is long-term infectious. So as the infection is progressing toward the higher fibrosis stages, the NS5A RAFs may accumulate in the person. And lastly, again, a small amount of data, 41 people failing NS5A, 90% have the resistance. So the resistance issues will be there. We see that if a person is failing DA, they will have mostly Y93H mutation in more than 80%. And this mutation will prevail over time, so the NS5A resistance is being kept, while the protease resistance will be declining over time. So probably we could be retreating people with protease inhibitors faster than with NS5A inhibitors. So this is all which I wish to show you. Actually, it cut a half of a quote. The first part was, if you want to stay in one place, you have to run as fast as you can. This is from Lewis Carroll, from the Red Queen theory. But if we want to get somewhere, we need to try to run twice as fast as we can. So maybe this is the quote for the elimination for Hep B and Hep-C in the future. Thank you.